Good morning to all. Myself, Dr. Kamali, doing post-graduation in the Department of Conservative Dentistry and Endodontics at Sri Balaji Dental College, Bharat University of Higher Education and Research. Today, I'm going to talk about the topic of management of intracanal separated instruments. Mistakes are painful when they happen, but years later, a collection of mistakes is what is called experience, which leads to success. These are the contents I'm going to talk about. There are three factors affecting success in broken file removal. First is profit. You need to earn money for the procedure you do. Otherwise, there'll be a lack of motivation, which will affect the predictability. Introduction. Instrument separation may occur during the use of several endodontic instruments and or rotary gates, lentilopluggers, spreaders, which is made up of different materials like nickel, titanium, stainless steel. Instrument separation will prevent access to the apex most of the time, impedes full-length instrumentation and obturation of the root canal. Frequency of endodontic instrument separation. According to clinical studies, the overall endodontic instrument separation frequency is between 1.83% to 8.2%. The frequency of rotary instrument separation ranges between 0.13 to 10% and includes several kinds and types of instruments. The manual instrument separation frequency is 0.25 to 6%. The highest frequency of instrument separation is presented during the treatment of molars, that is 77 to 89%. Greater risk of separation occurs during the treatment of lower molars, 50 to 55%, compared to upper molars, 25 to 33%. Diagnosis and treatment planning. What you will start with instrument retrieval. You will see a radio opaque file or any gates ridden or pluggers peeking out of the apical foramen, out of the root in a IOPA or CBCT assessment. What case is considered easy for instrument retrieval? The success rate for removing fractured instruments is approximately 2 times greater when it is visible inside the root canal than it is non-visible, according to Giselle Navras G. et al. Location of coronal end of the instrument is important to assess the difficulties of instrument removal. Do you need to remove every single instrument? First of all, you have to inform the patient about the presence of broken instrument. Then you have to remove the broken file that hinders cleaning and shaping the canal with periapical lesion or symptom. You can leave the broken file alone if the tooth is asymptomatic or there is no lesion associated with the root. Why do you need CBCT for broken file removal? In case of panoramic 2D radiographs, you can see only on two aspects of the root. Either you can see two canals in a single root or two separate canals or a single root or a file outside the root or one of the three canals or at the end of the oval canal. CBCT is must for an accurate diagnosis and treatment planning. First, you have to see a lesion associated with the root, then measure the broken file length, measure the curvature, locate the inner wall of the curved wall, see the cross section and thickness of the canal wall, then find if there is any presence of vertical root fracture and perforation, then refer to the axial view when preparing the canal under microscope. CBCT based root canal measurements are accurate and reliable when compared with the gold standard measurement. So this is the CBCT image. You can see the measurement of 3 mm of the root, which is exactly similar when you measure it outside the root canal. Why do you need to measure the broken file? The longer the broken file and greater the curvature of the file, the more challenging it becomes to remove the broken file as it engages all over the root canal. A study by Terauchi stating the relationship between the length of the broken files and broken file removal time with ultrasonics using 76 broken files from curved or straight canals. If the length of the broken file is more than 4.5 mm, you can use Terauchi loop instead of normal retrieval technique. A study done by UJ states that mean length of fractured instruments is 2.5 to 3.5 mm. Highest fracture incidence is with larger diameter files. 47.5% separated instruments are seen in mandibular molars, 61.5% seen in maxillary molars, 91.4% seen in the apical third, and 54.2% separated files seen in severely curved canal, which is more than 25 degrees. There are several methods to remove a broken file. That is mechanical, chemical, or surgical. In case of mechanical, you can use ultrasonic tips or Terauchi file retrieval kit, forceps, laser. Chemical by use of dissolution of fractured instrument. Surgical by periapical surgery. Ultrasonic removal. Ultrasonics is the most effective for broken file removal in terms of time, dentin sacrifice, and success rates. 80% to 95% unsuccessful under the microscope, only 47% successful without microscope. Comparison of ultrasonic scalars. There are two types of movement, elliptical and linear movement, and there are two types of ultrasonic instrument, magnetostrictive and piezoelectric. In case of magnetostrictive, the frequency is 20 to 40 kilohertz, and in case of piezoelectric, it's 29 to 50 kilohertz. The pattern is elliptical in case of magnetostrictive and linear in case of piezoelectric. Energy conversion, metal rod or stack of metal sheets. In case of piezoelectric, crystals activated by ceramic anodes. Power dispersion, all surfaces are active in case of magnetostrictive, and in piezoelectric, only active on the lateral side. How to place a tip in the canal? If the ultrasonic tip is placed in a tight space, it will break. Comparison of the time required to create secondary fracture of separated file fragments by using ultrasonic vibration under various canal conditions. This study is by Terauchi. So without supporting wall, instruments fracture faster. Most resistant to fracture when curvature is 30 to 45 degrees with dentin wall support behind the ultrasonic activation site. Each generation with ultrasonics can cause necrosis of the periodontal tissues. Ultrasonics potentially generate enough heat to rise the temperature of the external root surface by 10 degrees Celsius or more. So temperature elevation of the periodontal ligament in excess of 10 degrees Celsius can cause damage to the attachment apparatus, according to Erickson et al. Conditioner for broken file removal. In case of dry canal, there will be eye visibility. Cooling can be done with air blow. Cooling ineffective in the apical third. Susceptible to secondary fracture. Heat generated by ultrasonics might cause damage to periodontal tissues. In case of wet canal, low visibility, cavitation effect will be there. Acoustic straining. Cooling very effective. Heat is not significant. Recommended fluid used for broken file retrieval procedures. The viscosity should be low to medium. Surface tension should be low, which will lead to higher permeability. Lubrication should be high, which leads to medium viscosity. Mixture of silicone oil plus Q-mix 2 in 1 in the proportion of 3 to 2. Preparation phase, you can use silicone oil with low surface tension to loosen the broken file. In removal phase, you can use soybean or corn oil for broken file removal in a severely curved canal. Mixture of soybean or corn oil and Q-mix 2 in 1 for broken file removal. This is Terauchi file retrieval kit. It consists of 5 instruments, that is Yoshi loop, spoon tip, straight tip, modified 3 GG burr, and micro trifine tip. The medium used are silicone oil, soybean oil, and Q-mix 2 in 1. First, you have to create a space using a burr. Then you can use a micro trifine burr to create a space around the broken file removal. Using a spoon tip, you have to create a 90-degree space, 360 degree space around the broken file. Then using a straight tip, you try to retrieve the file, use the medium, then ultrasonic activation can be done. There are two types of tips, ET25 tip and Terauchi file retrieval kit S tip. So in case of ET25 tip, the tip diameter is 0.6 mm, which is quite large for narrow canals. In case of Terauchi file retrieval kit tip, the tip diameter is 0.1 mm, so it creates a semicircular space around the broken file. When compared with CPRA tip, TFRKS, that is Terauchi file retrieval kit tip, is very narrow and it is more convenient to retrieve a broken file. Always the space around the broken file should be of thin and small diameter. In case of large diameter, more amount of dentin will be sacrificed. In case of progressive taper, the ultrasonic tip will get engaged at one point. So small diameter is ideal. Ultrasonic preparation should be done until the file gets loosened. There is a concept of file dancing. It is defined as a file going from one place to another. File flexing is defined as a file going from one place to another and returning to the original place. Ultrasonic removal of the broken file, you can also use olive oil or EDTA as a medium. Then up-down motion within the space can be done for the removal of the broken file. Always keep some distance from the broken file. You should never attach the ultrasonic tip parallel to the broken file, which leads to its fracture. There's a 10-second rule for instrument removal. Statistic shows 94% of the separated instruments below 4.6 mm came out of the canal with ultrasonics in 10 seconds. Yoshi loop. You can use Yoshi loop with the broken file longer than 4.5 mm or broken file didn't come out in 10 seconds with ultrasonics. Always bend the loop of the Yoshi file at 45 degrees, then at 90 degree and remove the broken file. Removal of a flexing file longer than 4.5 mm, you can also use XP endo shaper. Since it has a snake-like motion, that is serpentine motion, it will just vibrate inside the canal and remove the broken file. Summary, when the length of the broken file is less than 3 mm or equal to 3 mm with any curvature of the root, ultrasonics can be done. If the file length is 3.1 mm to 4.4 mm with more than 30-degree curvature, canal curvature, you can use loop or ultrasonics with oil or XP endo shaper. If the file is more than 3.5 mm with any curvature or straight canal, you can use loop or ultrasonics with oil and XP endo shaper. Thank you.